pandemic along with the associated. And we were getting thousands and thousands of viewers. And the other Jmore business and Jmore health events we've done have gotten thousands of viewers. So thank you all in the online audience as well. Let me thank LifeBridge Health, one of our sponsors, the law offices of Nemphos and Braue, Sheppard, Pratt, and the University of Maryland Medical Center, all wonderful sponsors of this event. So thank you all for your help. Let's give them a little hand, please. I want to take a moment to talk about one of our hosts this evening, George Nemphos. Where's George? George? There you are, hiding in the back. George not only helps sponsor this, but as always, he's integrally involved with these events. George, and I got this long bio, and if I read it, everybody would fall asleep. I mean, so I don't think there's great stuff in it. And he's got an amazing background, including Georgetown and other places. But what I really want to talk about is George is a corporate lawyer. I mean, really, as talented a guy as you're going to see in Baltimore, has done a lot of work for Jmore, for myself, for the businesses I'm involved in. Just involved recently in raising $20 million from a company that I'm involved with, and manages to do that work, low ego, not having to prove anything, just to get the deal done, which in a corporate lawyer, as some of you appreciate, is really a talent. Just gets it done and gets it done efficiently, and is tremendously talented. He also made the mistake of traveling through Africa with me once, and I managed to get him up in a hot air balloon over the Serengeti. I am pretty sure that he had to wear a diaper on that, but no, just kidding. But we were over the Serengeti at about 1,000 feet with a not very friendly pilot taking us over the Serengeti, looking at herds of elephants below us. So pretty amazing. But anyhow, George, thank you so much, and I wanted you to come up and say a few words.
I don't even know how to follow that. Other than to say, no, I wasn't wearing a diaper. But let me tell you, I white knuckled it the entire time we were there, to the point where Scott was absolutely laughing at me. We were in this hot air balloon with I think, Scott, what was it, 12 people? 12 people, and this German pilot, full on hardcore accent, and was like a drill instructor the whole time. And he turned and said, "Look at the camera." And Scott looks at me, and he's across the way, and I'm across the way, and we're both going like this. And he yells at both of us without even looking at us. He's like, "You two, hold still." So, yeah, so that was an interesting experience. But I do tell you, go to Africa if you get the chance. Maryland Zoo did a great job setting it up. But that all being said, on behalf of Nemphos Braue, we're really happy to be here. We're longtime supporters of Jmore and the entrepreneurial series. We believe very strongly that as a community and the ecosystem, we need to work on this even more so now that we're finding our way through COVID, and that, in order to replace a lot of the jobs that we've lost, provide better access to healthcare, and give ourselves an opportunity as a community and in a state and a nation to recover in a way which is a leap forward rather than 2 baby steps back into the pool. We really feel that these events will provide a lot more energy and assistance in launching new careers, technology, interests, and partnerships. Scott mentioned that while COVID has obviously affected the number of us that can be in a room together, these events are watched over and over and over with thousands upon thousands of views. And we find them to be, and hopefully you'll find it to be, very informative, enjoyable, and at least you'll get to hear about me, I guess, wearing a diaper. Thanks, Scott. So with that, I'm going to turn it over to Gary Stein. Gary's an old friend. He's fabulous. Don't let him kid you. He knows he's fabulous. He's happy to tell you he's fabulous. But with all that said, I think, Gary, we'll leave you to work your magic this evening.
And I don't know how I'm going to follow that. So thank you, George. Appreciate it. Oh, a quick announcement.
I'm sorry. Thank you all for coming. I do want to thank Citron for this fabulous venue and for delicious food. Thank you to Susan and Charles. This has been really terrific. And I would encourage you, if you have not eaten here when you're done this evening, which we should end within the hour, absolutely go over to the bar and the restaurant and order food and enjoy yourself. So thank you again.
Having said that, I should get my phone out here so I know what time we got. Thank you. That's a good idea. Hold on one second, guys. I'm going to do it. I can do two things at once. Yep, we got it. Okay, perfect. And I would like to thank also Jmore for creating this event. The sponsors, as Scott mentioned, George, of course, my good friend, and Susan and Charlie here at Citron. We have reservations for Saturday night at 7:15. Thank you so much, Susan. I really appreciate it, and I encourage you to do the same. A reminder also, we are streaming live, as Scott mentioned, and this content will be available on jmoreliving.com after the event, so it'll live and hopefully live forever. Our goal today is to talk with our esteemed panel of medical professionals about innovations in healthcare, how each of their organizations are innovating, and how that will impact the future of healthcare here in Maryland and obviously elsewhere. And let's not take for granted for a minute before we get to our panelists about how blessed we are for the quality of care that we do have here in the state of Maryland. According to a recent study conducted by WalletHub.com, Maryland ranks 5th in the nation based on variables such as access, cost, and outcomes. So we are very blessed to have that available to us. Let's start with our featured speakers. And when I introduce them, I also like to ask them just a quick question about what perhaps motivated them to get into the field, so we can learn a little bit about them, maybe how they tick, what they're like, as opposed to just the clinical medical stuff. So without further ado, we'll start from all the way on the end and work our way back towards this way. Dr. Jonathan Thierman, Chief Medical Information Officer for LifeBridge Health, Chief Medical Officer for LifeBridge Health Partners, and the President of the Medical Staff at Northwest Hospital. LifeBridge Health is one of the largest and most comprehensive providers of health-related services to the people of Greater Baltimore region. Jonathan, welcome. And tell us why you do what you do.
Happy to be here. Thanks for inviting me, and LifeBridge is happy to sponsor the event. Why I do what I do. Well, it seems that what I do keeps changing every few years. The last 2 years were a big change, so it's an evolving thing, but it always centers around health. And you know, I guess my background is kind of a nerdy engineering background, but with a focus on health, because it's the ultimate you know, ambition to improve the health of people. So I feel like sometimes I'm in the ER working clinically with people directly, improving their health. Sometimes I'm in an office designing a program for LifeBridge to give access to people for health. But it's the same theme, which is basically improving the health of our communities. So that's why I do what I do.
And was there ever a time where you considered anything else as a career, or it was always going to be medicine?
I mean, when I was 8, I wanted to be a chef.
Susan?
And you know, I wanted to build rocket ships when I was probably my first year in college. And then after that, I realized there was some really cool technology in healthcare. So cool. After that, it was all health.
Okay, sounds good. And then right next to Jonathan is Jennifer Main, the Chief Operating Officer and Chief Financial Officer of Amalgam RX. Amalgam RX is a leading digital platform that connects healthcare providers, payers, and life sciences companies, so important and growing in importance to our future healthcare landscape. And Jennifer, welcome, first of all, and I hope I don't throw you off balance with this one, but I noticed from your bio that you were a history major at Cornell. So from a history major at Cornell to this panel, what happened there? How did that happen? There's a little button there. Okay. Pause.
Thank you.
There we go.
So that is kind of a big, long stretch. I'm going to cheat and say what I was going to say before. Well, actually, I'm a huge fan of good liberal arts undergraduate, like learning how to think about a wide variety of things. I took a class on Florence from 1250 to 1530. I actually learned a ton that's not like directly relevant, but amazingly close. So I did go to graduate school and became really, my career is financial management and operations. I've been a CFO, probably 6 organizations. And I got an opportunity in when I was sort of mid-career in 2014 or 15. And I was thinking, okay, I need to keep working, but I really could work. I could think through what I want to do and what I really care about. And up until then, I'd never worked in, I'd worked in housing and finance and things like that. And I learned around that time that the United States spends at least 50% more on healthcare than the next closest first world country. And yet we rank 28th, 29th, 30th on some of the basic statistics of healthcare and mortality and things like that. And I was like, that is just stunning. And as a person who's interested in finance and learning that healthcare was 20% of our economy, and yet we were outrageously overspending compared to what we get for it, I got super interested. So I actually went to the Centers for Medicare and Medicaid Services just down the road. I got to drive by it on my way here. I live in DC. So Security Boulevard, I'm sure some of you are familiar with it, is a big employer in this area. I worked at CMS for 5 years. I was the CFO and then the Chief Operating Officer. And it was awesome and super interesting. And I just left last spring and joined Amalgam because they're actually doing some cool stuff that I learned about while I was at CMS. So that's my bridge
Which
from
we
my
will talk
history
about.
major to today.
Yep. And just a quick question. Did you enjoy the winters in Ithaca, New York, or how was that?
I grew up in Michigan.
Oh,
and
okay.
I went to grad school. I went to college at Cornell and grad school in Boston. And it took me a long time to adjust the fact that you need a winter coat down here. I kind of blew you guys off. I was like, it's not really winter. But I did finally get wizened up to that.
Gotcha. To Jennifer's left is Marina Cecchini. She's the Chief Administrative Officer at Sheppard Pratt's new Baltimore, Washington campus located in Elk Ridge, Maryland. Sheppard Pratt is the largest private nonprofit provider of mental health, special education, substance use, developmental disability, and social services. And Marina, congratulations, if I'm not mistaken, on accepting the job, because it's not been that long, right? In March, April of 2021, congratulations. You were down in Florida before that, Central Florida. So give us your take about coming from 85 degrees, although it's been warm here in the summer, to what you await here in the winter up here. And you are on.
Well, very similar to Jenny. I went to elementary and junior high school in South Florida, and then my family moved to Utica, New York, and we had 200 inches of snow in the first year. So I've already had my culture shock around weather. And when I left Utica and moved to the New York metro area, I never wore anything heavier than a jeans jacket for the entire first year. So, but no, I'm very, very delighted to be here. I'm excited to be part of Sheppard Pratt because as we talk about innovation, we can talk about mental health being an issue for all eternity.
Absolutely.
And only in this era really addressing it in creative ways. So it's a very exciting time to be here.
We do want to talk about that. No doubt it's finally being acknowledged as a thing, right? And I think we absolutely need to talk about it. Immediately to my right is Dr. Aaron Rapoport. He's the Gary Jobson Professor of Clinical Oncology and the Director of the Transplant and Cell Therapy Program at the University of Maryland School of Medicine and the University of Maryland Marlene and Stewart Greenebaum Comprehensive Cancer Center. UMMS is a university-based regional healthcare system serving the needs of Maryland. It also happens to be one of the state's largest private employers with over 33,000 employees and affiliated physicians. And Dr. Rapoport, welcome to our panel, number one. Number two, you oversaw, among many great accomplishments in your career, our governor, Larry Hogan's successful treatment for stage 3 non-Hodgkin's lymphoma back in 2015. Thank you. But what really struck me as I researched you a little bit were I wouldn't say the reviews, but just the comments from like former patients, current patients, et cetera, how compassionate you are to your patients, how they feel about that. And, like in sports, you can't teach speed. I don't think you can teach compassion. So my question to you is, where does it come from?
Thank you, Gary. Thank you for the opportunity to be here. I would say my first entry and interest in medicine came from my father, who's a distinguished physician and physician leader, as well as my mother, who is a mental health professional. And so they, I think, really inspired me to enter medicine. I became a hematologist and oncologist because of a mentor that I had in internship and residency named Jacob Braue, who would go to the nth degree and the ends of the earth to care for patients, and was always available to them, and just loved what he did and loved the opportunity to bring the best care and the best medicine that he could bring to their life-threatening illnesses. So I was really inspired. I was highly mentored, and I modeled myself after them.
That's a great answer. And also, and as I'm sure everybody knows, compassion not only towards the patients, but the patients' families. And that's, so important when you're going through that situation, that the families are well taken care of as well. So, okay, let's start with, and now we've introduced everybody, so hopefully we have a little bit of an insight into everybody here on the panel. Let's go back all the way over to the other side, to the West Coast over there. Jonathan Thierman, specifically as far as innovation is concerned, LifeBridge Health, and you specifically, telehealth. Let's talk a little bit about that. You have led LifeBridge into the digital medicine era with initiatives that include a system telehealth platform, big data analytics, with the hope of, and you have, increased patient access and in-patient care. Here are just a couple of numbers to see how this has grown, especially through the pandemic. January of 2020, this is before the pandemic, I think you guys were at about 2,000 visits a month, and they were mostly, if not all, ER related. 1 year later, January of 2021, during pandemic, 10,000 visits a month, and not only ER, but now primary care, just regular old mundane kind of stuff, because people couldn't go to see their primary care physician or couldn't go to the hospital. Talk about the growth, number one, and the explosion. Were you guys actually ready for that type of situation?
Yeah, good question and good research, by the way. You got some good numbers, and I didn't give those to him. So we, at LifeBridge, we've been trying to look ahead and down the road for a while, and so we began our telehealth journey a number of years ago, preparing for the pandemic. No, not preparing, but preparing for the future, and we were prepared for the pandemic because of that, in that aspect. So we had a telehealth platform that was system-wide, that was set up, that was good for everything, but as an ER doctor, I looked for where I could get the most impact and get it landed. And I was able to successfully get the ERs at LifeBridge to adopt telehealth initially. So that's where we were doing the most telehealth, and we were doing it with, we were doing teletriage. So we were able to leverage a provider in one of our hospitals to see patients at the other hospitals so that we could kind of load balance our load. If one hospital was extra busy, another hospital could help out in the ER. And that's where we were hitting in the low 20,000 a year for a couple years. But we had this platform, and I was literally banging on doors with our primary care providers and others, trying to get them to adopt the future. And then when pandemic hit, some of them did, but when the pandemic hit, the patients demanded it, essentially. I mean, no one wanted to go into a primary care office in the early months of the pandemic. We probably evened out at about 10,000 visits a month, but in the month of June of 2020, we had like 18,000 visits in a single month. So we hit well over 140,000 visits that first year. And we were ready, but still overwhelmed all at the same time. It was a learning curve. One of the reasons why telemedicine was difficult, there are many reasons why it's difficult to get it up and running, but there's a learning curve for the providers. There's a learning curve for the patients to be comfortable and accept this new modality. There's a learning curve for CMS and others to accept that it's worthwhile paying for, and it's actually a good idea to do it this way because it can save money in the long run. And so there's all these different obstacles. And for better or for worse, COVID, the pandemic, bore a path for acceptance and a lot of legislative changes that allowed for the use of telemedicine, the reimbursement of telemedicine, and frankly met the needs of the patients who were demanding telemedicine because they didn't have access otherwise. So if you look at the curve, and I'm a data guy, so I like to keep all the curves, we hit this peak in summer of 2020, fall of 2020, and it started to decline. After that, when people, it basically shadowed the pandemic numbers. So when things were doing better in the state, people were starting to come back into the offices, and appropriately so. And so we've kind of hit a steady state now, and I'd say roughly 10 to 12% of system-wide of our visits are telehealth now, and that's probably an appropriate place for it to land. It was 80%, 90% at the peak of the pandemic, but in a normal world without those types of fears, there's people that need to be seen in person, there's people that want to be seen in person, and then there's things that need to or could be seen remotely. And so we're at about 10% patient visits, and that's probably an appropriate landing point. We've been there for months now.
So here's probably the most important question as you look to the future. How do you begin to evaluate what investments or policies need to happen? Where would you get the most bang for your buck in order to cement telemedicine as a staple, as a fixture for future healthcare?
Good question. Certainly, mental health is a huge opportunity for telemedicine, and we're trying to do our part in terms of providing services for remote access to mental health. And the other thing is there's new modalities for telemedicine that are coming online that probably make it even more efficient than the way we were operating before, which is just pure video. So I'm really excited about a newer kind of pathway, which they call asynchronous telemedicine, which essentially is the patient goes first, they interact with the questions, and the provider goes next. So they're not in sync. They're not doing it at the exact same time, but it leverages the provider's time a lot more efficiently. And so the providers can see a lot more patients, essentially. So I think that's a future landing point. That's a place in the world of telemedicine that's not well reimbursed and not well accepted yet, but I hope we will get there, because then a single provider can see twice as many patients, because the low acuity things they can do in this method and the higher acuity things they can do in person or video or whatever.
I have one final quick question, and then I'm going to move on. And correct me if I'm wrong, because you know a lot about this more than I do. But doctors need to have a license to practice medicine in the state in which they practice, correct? But telemedicine would lend itself to a doctor being able to provide medical advice to anybody in the world. So what about the licensure issue of medical professionals to be able to access that ability?
These are great questions. So these are big questions. And this is where I think the rules are falling behind the what's best for patients and what's best for healthcare. And we happen to have 50 states, but more or less medicine is done pretty much the same. I mean, there's a couple of carve-outs, but more or less medicine's the same across our 50 states. So the idea that a doctor, there's these advertisements for Teledoc, come work at Teledoc, prefer physicians who hold over 25 licenses, which is a crazy idea to apply for and pay for and maintain 25 state licenses. So I'm hoping that we get to a point where there's a lot more reciprocity between states, and maybe even there's, some, for telemedicine anyways, there's a national license, because, pink eye by telemedicine in California is pretty much the same as pink eye by telemedicine in Maryland. During COVID, there was a lot of lax with the rules. There's a lot more reciprocity, and a lot of states, about 27 of the states, have actually come forth and said, fill out this one-page paper form, and you can practice in this state because we need the help, whether it's telemedicine or actually in person. You can drive over and practice because we need the help during COVID. So there's been a lot of changes that are temporary, and I'm hopeful that people will start, when I say people, I mean like legislators will start to see that, nothing broke, no one got hurt, and it was not a bad thing, and maybe they'll loosen up a little bit on some of these rules, at least for telemedicine, because it doesn't make sense, like you pointed out, to have 50 licenses to practice, across 50 states. I'll tell you locally, there's reciprocity with states that touch Maryland. So I can do telemedicine in Virginia or Pennsylvania or Delaware, but I can't do it in Massachusetts without applying for a license, or Florida, which is actually pretty tough to get a license. And I can do it in California now if I fill out a one-page form, but in a year, maybe I can't. So anyways, that's the state of where we're at right now. And I'm hoping that we evolve quickly and catch up with the state of technology and get to a point where these types of regulations are a little bit more forward thinking.
Gotcha. All right, so we're going to circle back to you a little later. I wanted to move on to Jennifer Main, the Chief Operating Officer and Chief Financial Officer at Amalgam RX. So you actually told us, Jennifer, that you did make a big change in your career. Not only from history to medical administration, but from the Center for Medicare and Medicaid Services, CMS, to a small, early stage digital health company that is developing groundbreaking patient support programs to transform the delivery of care. So my question to you is, as we talk about innovations, what are you most proud of, and what are you seeing in the innovations as you try to connect patients, providers, and insurance companies together so that everybody is on the same page and everybody can make the right decision for that care? Because that's what your company does, basically.
That's what we're trying to do.
Right.
Us and a lot of folks, because it's challenging, right? So I think, I would, so I went to the Centers for Medicare and Medicaid Services in 2016 and just had a, great opportunity to sort of learn this, a lot about healthcare from that seat. Medicare and Medicaid combined, it's a $1.4 trillion spend of all the different programs that many of you, I'm sure, are quite familiar with. So it's a lot of all the segments in the healthcare market. And a couple of things that I learned there that were particularly struck me in terms of the future of healthcare and what's happening. One is this notion of value-based care, right? We want to pay for outcomes. We want to pay for doing the right thing. If it's preventative care on the front end that saves money and makes you healthier, then of course we should spend the money on preventative care on the front end rather than paying for all the expensive care on the back end because we didn't do things we could have done on the front. And, again, as the newest one on this panel to healthcare, I get to, call my newbie card here. Mm-hmm. In the 1990s, we had HMOs, right? They had the same idea. They said, we're going to keep you as a healthy person rather than let you get sick because that would be more expensive for us and it'll be worse for you. So here we are, I was 2016 and I'm like, we did the HMO thing 25 years ago and that apparently wasn't good enough. So another jump forward, the Affordable Care Act in 2010 created the Center for Medicare and Medicaid Innovation. CMMI is the thing for it, but the key word is innovation, the Innovation Center. And it's funded, I have to admit, when I got there, I thought it was funded for 10 years for $10 billion, which is $1 billion a year for 10 years. And so as the CFO, and I was like, well, this money's going to run out. What have we learned from this? Well, it turned out, no, actually it's $1 billion a year, in perpetuity. So just so you know that for in the scope of how big our budget is. And so I said, okay, we've been in 10 years in, the Affordable Care Act is 2020 now, or closing in on 2020. What have we learned? We've spent $10 billion almost in looking at innovation, and they had launched close to 50 different models. They're called models to try to figure out what is it that's going to work to help us in all the different places that you could apply some better incentives, potentially incentives for providers, incentives for patients, all those different things. And so when I was at CMS, we did a retrospective of, okay, what have we learned over the last 10 years? And one of the key things that really stuck with me, there were a number of things, but one of the things that really stuck with me was the friction in the daily and hourly interaction between a patient and a provider. The friction is still really high. The patients and the doctors and the providers don't have, and particularly the providers, don't have the right information at the right time at the point of care, when they really need it, in the room when things are happening. And instead, you make the best decision you have based on what's there, and then you find out later, oh, the insurance company doesn't pay for that procedure that I suggested you do, or I needed to actually write it in a specific way, and that requires 2 more visits to actually get your prescription or your referral written the exact way to go to a place that they'll pay for it. And it's way more complicated than people can deal with. And I know, you have to have an app to go to Panera, for God's sakes. Every one of us, right? Every organization you go to wants to have all your information and a secure app and a new password. And so if you're a patient, you have all these different healthcare, now new relationships. And I'm sure if you're a provider, which I am not, but if you're a provider, you don't want to have 40 different apps that you have to go to interact with your patients. So and on one hand, it seems like, yeah, it's digital, it's great. And on the other hand, like, who are we kidding? I mean, I have like a vault for all of my, like a physical vault for my passwords. It's ridiculous. So the key point is the friction in the system is way too high. And it's actually so high across the whole thing that it's a big part of our cost. So to me, like light bulb, like figuring out how to bring down this friction so that there's real actionable data at the point of care was something that I really took away from my CMS time. The other was, I think all of us, most of us can think back to where we were the weekend of March 16th in 2020, which was on Friday, the world was sort of operating normally. And on Monday, I can say that every person at CMS did not report to a building for the first time in the history of the organization. We didn't even have one practice day where we all stayed home. We were too busy to do that. So we just did it live. And the good news is it worked. But, over the next 4, 5, 6 months, I think the entire world changed in terms of what we think of as possible. And all of the things about telehealth that made total sense to you, but you were having a hard time convincing people that they were doable. Now we've changed so much so fast. It really accelerated people's comfort and acceptance with a lot of new ways of doing things. The telehealth is the obvious one. And then there's all this data that goes to support it. And that's what my company does, is we have apps that, collect data and help you, a particular example, insulin titration, getting on the right dosage of your insulin. It's actually half the people, who are on insulin are on the wrong dosage. So because it's a pain to get, you have to go back to the lab, then the lab has to send a thing to your doctor, and then the doctor has to call you, and then you have to call back and find out when the doctor's free. So you can, break through all that stuff and figure out, oh, I need to change my dosage. Well, guess what? We can actually have an app that can help you and the doctor like real time know what's happening with your actual blood glucose sugar based on data that's real from you. So you see all these pieces and it's like, we can actually put this stuff together. So being at CMS and experiencing the pandemic made me realize this stuff's going to change really fast. And that's where the company that I work for now, Amalgam. Do you want me to talk about that?
Well, I was going to ask you, you talk about that friction, right?
Yep.
Right. So you're trying to ease that friction, but there's one other piece to the puzzle. You may have information from the provider, you may have information from the patient, but what about information from the insurance company? Because all three of them need to work together so that the patient knows what's covered, what I have to pay, because that's really what we're concerned is how much it's going to cost me, right? So right. Is that working for you?
Yeah. So really, as simply as I can say it, what Amalgam has, we have two different things, two different sort of products. One is the products that patients would be using, the app that helps you with your drug. And the other is we're now integrated into the electronic health record systems that are in the provider space. So the big ones that, Cerner and Epic that we're in like four of the big four that are 70% of the market. So that means that we can pull that information about the patient into the space where the provider is. If the insurance company wants to work with us, and we have some payers that we're starting to work with, we can actually have that there. So that like live information of your insurance company will pay for this thing can be in the space you are with your doctor. And it's only a matter of time before that is real for everyone. Like as patients, right? Of course we should expect that. And we'll get there eventually. So that's what my company's up to. And when I was at CMS and I learned that, I was like, wow, these guys actually are doing some things that make sense to me. So that's how I would bridge the big picture of the trends and then an actionable, a company that's trying to do it. So that's what made it exciting.
So we're going to circle back to you as well. Onto Marina. Marina, your experience as a hospital executive covers a lot of ground: psychiatry, addictions, physical medicine, rehabilitation, home care, medical surgical hospitals. It's been quite a career. But now you're with Sheppard Pratt, and the exciting news about the new facility in Elkridge, Maryland. I think it's 156,000 square feet, if I'm not mistaken. Just talk to us a little bit about the opening of that, number one, and then let's get into the mental health conversation, because I think that is so important today.
Thanks. We opened our hospital June 28th, and it's 156,000 square feet. It's 85 inpatient beds, which isn't a tremendous number of inpatient beds, but I've been doing this for 29 years, which is how I got to have all those experiences. And, the reality is what we need today to treat people in the mental health space is very different than what we needed 29 years ago. The people we're seeing are coming to us in crisis because of all the people who previously may have been in institutionalized setting are now in community settings. And when they go into crisis, they need instant access to care. So in addition to the inpatient beds, probably the innovative thing, and Sheppard Pratt has been doing it in Towson for a long time, is that we have a psychiatric urgent care center. So it's an urgent care center for mental health psychiatric needs, very similar to if you fell and broke your arm, and rather than going to the emergency department to wait and to incur all the expense and all the tedium sometimes that can then come with going to the emergency room, now people can come to us in crisis and we can do an evaluation and make a referral for the appropriate level of care. Some of those patients do end up needing to be hospitalized, but about a fifth of them end up getting referred to the day treatment level of care. That's the other thing that we are using this magnificent space for. So we've got an adult day hospital open right now, but we've got designated space for 3 more that will be opening soon. We also will have one for patients with thought disorders. We have one for adolescents 12 and up. And then we have one for eating disorders that's going to be, it's our largest day hospital space. And it's been designed out so that we can treat both adolescents and adults with eating disorders in that space.
So I'm curious to know, is it possible to compare the volume of patients that you see or that they saw pre-pandemic to today? And I'm getting at the pandemic's effect on mental health.
I think there's a couple of responses to that. One of the things is, while we only added 8 inpatient beds, we went from semi-private to private rooms. And the pandemic's impact on us was that by following our infection control protocol, we had blocked second beds in double rooms all the time. So almost immediately, our census actually went up by about 20. So it was excellent because the community was kind of pounding down the doors needing access to care, and this was a way that we could provide it more effectively. So I think that's one thing. The other thing, and I know we're all saying the same words, but telehealth really came of age in mental health during the pandemic. So not only were we doing day hospital programming with telehealth, but also, and we continue to do some psych urgent care appointments via telehealth. So people in crisis who may not be able to make it to the hospital, still need a recommendation, still need to take the next step in resolving the crisis, can actually call us. And we've got people in Towson and at Elkridge, where our Baltimore, Washington campus is, who are available to do those appointments via telehealth.
And just out of curiosity also, and I'm just going to throw out a couple of sports names for people who may know: Simone Biles, perhaps the greatest gymnast in the sports history, Naomi Osaka, who now is a young, fantastic tennis player, have both come out and talked about their mental health issues. And I wonder, with that kind of exposure from those types of individuals, what impact that's having on people, I'll just call them quote unquote regular people coming forward.
I think we've brought up an entire generation of young people who are more open to treating mental health as health.
Right.
And so, these are young athletes who are doing that. It wasn't that long ago. I'm a sports fan, so forgive me, but where, Brandon Marshall actually was fined for wearing the green shoes in support of mental health when that wasn't the team line.
The pride of Central Florida, if I'm not mistaken, correct?
So I think I look back, and 30 years ago in New Jersey, I got put on the anti-stigma task force. And, it felt like we were running into a wall for decades. And all of a sudden, there, I think, is this tremendous recognition that mental health is valuable. The schools are definitely doing more with it. And I think what makes Sheppard Pratt unique is I may be in a hospital every day. That's only where the people who need the most intensive level of care are. We have 380 service sites. So when you look at how mental health manifests itself and how Sheppard Pratt meets that need, we've got everything from housing, homeless services, addiction treatment, psychosocial rehab services, outpatient mental health centers. And so wherever someone is along the continuum of need, we are in that space. So that, you know, in spite of the season, I went to many, many Orioles games this year. But it is a privilege to work someplace that has such a forward-thinking philosophy towards mental health treatment. And being in every space, meaning the spaces where it's easy to do business, the spaces where it's hard to do business, but you're doing it because there's a true commitment, there's a philosophy and a care for people who have largely been underserved, underestimated, and really are deserving of help the way people with medical issues are as well. So that is in my heart what keeps me interested in coming to work every day and doing what I do. And I think that is really the core of what Sheppard Pratt did. Now I just have to brag for a minute.
Go ahead.
Okay. So I do a lot of tours of the new hospital. If anybody wants to come out and see me, please find me, because I love giving the tours, because I'm so proud. And I say for every tour, because we've got our leadership here who did a tremendous job designing this space. I've never been so proud of something I had so little to do with. but you know, we have built safety innovations. We have built it in a structure that is therapeutically designed. Light and nature are elements that you see everywhere. That was part of the philosophy of our founder, and it just manifests itself totally. So I'm very excited to show it off to people. And then I'll make you come into a sally port, where you can't open one door until the other one closes, from the Latin sale and port. I looked that up because I got asked a lot of questions. But you know what? The old and the new coexisting in terms of the traditions of Sheppard Pratt and today's technology. So I'll tell one quick story.
Okay.
We had a weekend where we had families able to come in for tours. My 15-year-old came with me. She went on every single tour with me. Her older sister was away for the weekend, so we went to pick up her sister at the end of the weekend, and she gets in the car, and the first thing my 15-year-old says is, they have 72 miles of wiring in her new building. But when you think about electronic badge access for security controls, when you think about over 400 cameras so that we're able to monitor what goes on, when you think about the communication needs of an environment where we want to keep people safe, everything has been taken into consideration. So please come see me.
So I have a quick observation to make. I'm a very big observer of body language, and I can tell you that you love what you do and you believe in it. So thank you for that. That was very, very well said, both spoken and body-wise. Thank you. To my immediate right is Dr. Aaron Rapoport. Dr. Rapoport, you have more than 30 years of experience in the care of patients with blood cancers, blood cancer research. In recent years, immunotherapy has now emerged as a promising treatment for certain types of cancer. The FDA has approved 2 versions of immunotherapy called, and I hope I'm pronouncing this right, chimeric antigen receptor therapies, otherwise known as CAR-T, C-A-R-T therapies. One version is for children, one version is for adults. So if you could explain to us why CAR-T therapy is good.
Thank you, Gary. Thank you, Gary. I would say that CAR-T and cellular immunotherapy for cancer is really a realization of a dream that those of us working in the field have had for many, many years and decades, to be able to harness the power of the patient's own immune system to recognize and fight against their cancer. We know the immune system is very, very important in controlling, preventing, controlling, and treating cancer. Patients with immune deficiency disorders like AIDS, for example, are at very high susceptibility to cancer, for cancers. And we've strongly felt that we could potentially harness the immune system and find ways of stimulating the body's own immune system to be able to better recognize and treat their own cancer. And with CAR T cell therapy, we have really come close to achieving that. What CAR T cell therapy is basically a form of personalized immune therapy for patients, where you take the patient's own immune cells, isolate them, and then genetically modify or genetically engineer the cells to be able to recognize and attack the patient's own cancer. And we actually have now 5 CAR T products that are available to patients to treat chiefly blood cancers, namely leukemia and lymphoma and myeloma. But there's a lot of excitement about developing new CAR products to treat other forms of cancer and to be able to make these treatments even safer. And the important message is that these treatments are able to treat and cure patients who hitherto had no effective options for treatment of their cancers.
So simply then, the outcomes you're finding are better through CAR T?
Well, they're not only better, I mean, anything's better than zero.
Correct.
And many of the patients that are appropriate candidates for CAR T therapy would have had about a 0% chance of long-term survival. And now with CAR T therapy, they have more than a 50% chance of long-term survival and cure. And that number is being increasing all the time.
Is anyone eligible for that therapy? Like I'm talking like body-wise, does it not work for some people?
Well, it really can work for really anybody. It is, as you said, approved for children, and it is all approved for adults. The oldest patient we've treated at the University of Maryland was 87.
87.
And he had a highly, very refractory, very resistant form of lymphoma that basically filled up his whole belly. He couldn't eat, he couldn't walk, he couldn't do anything, and all the chemotherapy and available treatments that we had for him had failed, and he was basically at the end of the line. We gave him CAR T therapy, and he's now almost a year out from CAR T therapy. He's cured, he's back on the tractor, he's enjoying life, and there are many other examples of patients like that.
Sounds great. So what I wanted to do now, just to be cognizant of the time, I did want to circle back, but I also wanted to open up for questions. We probably have time for maybe 3 or 4 questions, depending on length, etc. So if anybody in the audience has a question for any one of our panelists on any one of their specialties or their places of work, please feel free. We'll kind of open it up to the crowd. So the first one is always the most difficult one to get out of the way. I know that. So if anybody is courageous enough, there's a courageous individual. Sir.
I'm most proud of our mission and our values. It's at the foundation of everything we do. What I'm looking forward to is how we continue to have integration of all these different levels of care I talked about and all the services, so that the system works for the patient, around the patient, as opposed to the patient moving along a ladder in a more self-directed way, which for those with mental illness is really a challenge.
Okay. Next question for any one of our panelists. Tough crowd. Okay. George, for sure.
Sure, this question is for Jenny. Jenny, with regard to your products,
So I think the biggest challenge is just that we've seen is that, like everyone else, and probably more so, providers are inundated with things they need to do, and it's I think it's really hard to bring new stuff in. People want to be able to use things they're used to. There's, as we were hearing, there's just tremendous pressure. Telehealth isn't even fast enough. We need to segment it into multi-parts so that doctors can see even more people, which, I think for all of us, like you should reflect on that. People don't they go into medicine to actually help people heal and make them better, and engaging with people is part of it. And so if they're under that much pressure, it just tells you that they don't have a lot of free time and bandwidth to be learning new things. And the world's changed so much with technology. So that, I think that's really the challenge, which is why we're really committed at Amalgam to, we have to bring this to the provider space and make it as easy and adaptable and look like stuff they already have, so that there are no barriers. Take those things out of the way, and do that. And then, other parties like the payers in all of this are the ones that have the most incentive to help us align some of this stuff. So we've actually had some pretty good, reactions from them. We just need, I think the other thing that's also really interesting in all of this is this question of how effective is this stuff? We actually need more data on, sort of the real world evidence concept of how we've had so much change over the last few years. How much does an app make a difference about whether or not you're likely to stay on your medication? How much does an app make a difference on whether you're likely to take care of yourself in the way you're supposed to, some of the chronic conditions? How valuable is it to mental health? I think there's a lot of hope for some of these, but we don't really know yet. And then we're going to need more data to help us understand where it works well, where it doesn't, and where to keep innovating. I think it's just going to take time. And again, change is hard. Change is really hard. And you think about the technological shifts that have been happening, and it just makes complete sense to me that the barriers are just going to be there, and you have to keep making it easier and easier for people, and looking for pockets of where suddenly something happens and suddenly everything's, I can't get over the fact that I can do Zoom calls with people from all over the world. Like, everyone thinks it's the most normal thing in the world. And if you went back 2 years ago, just not the case. So those kind of shifts are really valuable. We want to take advantage of them and push to adopt new things that will really save us money and improve care, as best we can. I'm curious, you as a provider, if there's anything else you'd want to, like, what your perspective on that is.
Yeah, I mean, I started, clinically in the ER, working as an ER doctor, and I cannot emphasize to someone who doesn't practice medicine how crazy the levels of requirements are, how you're thinking about the patient's health, you're thinking about the insurance and what they cover, you're thinking about the patient's satisfaction with the service as you're giving the service, because that's an important thing too. I mean, you're thinking about how you're documenting, because if you don't document right, even if you save the person's life, you're not going to get paid for it. So then you're going to get fired for not putting the right things on the paper. I mean, it's a crazy, crazy amount of distraction from the focus, which is really just to take care of people. And so my first job in the technology world as the CMIO for LifeBridge Health was essentially to try and make it easier for the providers to do what they went to medical school to do, which was to provide healthcare, to try to provide an easier workflow in the electronic medical record. And so the things that you're trying to do in the startup, which is, a lot of what I do in that role, which is basically screen for, we have over 100 software vendors that we buy services from at LifeBridge that want to integrate in the EMR. And one of my jobs is to make sure that what they're putting in front of the provider is going to help them and not hurt them, and not be, because to many, one more click or one more thing to think about is just a little thing, but there's millions and millions of things, and many of them don't even have to do with the patient's health. So one more thing is a huge thing to think about. So, from my perspective, I agree. It's extremely important to make sure things are well integrated and to try and make the workflow easier for the providers to do what they're supposed to be doing, which is just taking care of patients and not worrying about all this other stuff. So, some interesting things that we're playing with. And the funny thing is, my job is to do this to providers, but providers themselves are pretty set in their ways and maybe reasonably so apprehensive about new things. And so one of the new great things that I think, which will be great, is decision support tools, AI and decision support tools, which are supposed to make the life easier for the provider. But in the short term, just like electronic medical records, they're going to be a little bit harder, or they're going to be a little bit more to do, or they're going to make mistakes. So it's going to be a learning curve. But eventually, having tools that will write the note for you or suggest the latest evidence-based treatment for that condition that the person comes in with, because no provider can keep up with all the latest, and it takes providers years. I just recerted for emergency medicine boards, and one of the things I learned in recerting, which no one knows because you don't learn it until you have to recert, is like, you're not supposed to put oxygen on someone who's having an acute MI if their O2 sat is over 90% on room air. That's brand new, hot off the presses. So, but no ER doctors do that because it takes 5 to 10 years for the latest research to make its way to the bedside, because they're busy taking care of people and they're not reading every single new journal. You just can't keep up. So the computer is supposed to help you, and so it's exciting. It will get there. It will eventually say, electronically tap on your shoulder and say, "Hey doc, maybe that one shouldn't have oxygen because the latest blah blah blah." But in the short term, it's going to annoy a lot of doctors, and they're going to be skeptical. And so I kind of have to walk that line between what's the future and what's going to help, but what also is going to make life easier for physicians practicing today. So that was a long-winded answer, but exactly what you're saying. We're always trying to make sure that new technology isn't slowing it down or making it harder to practice. It's only kind of helping.
And then it's accurate, right? Obviously that it's exactly that. Yeah, and I was delighted to hear that. It's exactly what our technology is trying to do, is to make sure that most recent, guidance and knowledge is coming quickly and easily into the space. It's hard. It's easier said than done, and it's a little bit at a time. But anyway, Thank you.
So I have a final question actually for Dr. Rapoport, if nobody else has a question, and that is, Dr. Rapoport, I'm just going to give you the concept of the cure for cancer. Okay, we've all talked about it, wished for it, read about it, et cetera, et cetera. You've been in the field for 30 years. Can you quantify or describe how much you knew back then versus how much you know now over 30 years? And are we closer? Can it be cured?
Well, absolutely. I mean, I think we are already curing cancer. We're curing cancer a lot more frequently than we did when I entered the field 30 years ago. Actually, a patient that I took care of as a fellow, so almost 30 years ago, was a young man in his early 20s when he was diagnosed with acute leukemia. And he came to our hospital, and one of my colleagues, as I told my colleague about the patient the next day, and he said, "Well, did you ask him if he'd made out his will?" And I said, "Made out his will? That makes no sense to me. I mean, here's a young man, he's already convinced he's going to die from leukemia. I have to communicate that there's a chance that he could live." And well, this is now 30 years later. Every holiday period, Christmas period, he writes me a card. He's updating me on his family. He became a respiratory therapist. He's now 30 years out from treatment for acute leukemia, cured. So we were curing cancer back then, and we're doing it even more effectively now. I think the exciting thing is the number of tools that we have, the number of range of medications. We're really dissecting what it is that drives cancer and enables cancer cells to develop, to grow, and survive. And we're able to target many of the molecular switches and molecular pathways that are driving that. We have a whole host of medications that are effective at suppressing cancer growth and driving it way, way down. And not only are these medications effective, but they're also much better tolerated. So the treatments are much better tolerated. Many leukemias can be treated with pills, with oral medications. And with the advent and the growth of cellular therapy, transplant therapy, CAR T and cellular immunotherapy, we are driving cancers into the ground and curing them. There's no question. It's actually very, very uncommon for patients who've gotten CAR T or engineered T cell therapy and are in remission for 6 to 12 months. It's very, very unusual for them to relapse after that. The curve is flat, and they have a very, very, very hopeful future. And so I think the message is we are curing cancer, lots of it, but there's still a lot more work to do. We need to be able to cure a wider range of cancer and to be able to do it, more safely and more effectively. One of the things about CAR T therapy that I didn't convey earlier is that it really does take a village to do it. That's why the University of Maryland was the first medical center in the Maryland, Delaware, Virginia region to be qualified to do CAR T therapy, and we are the most active and busiest. And we had to train upwards of 500 people who touched patients from our oncologists, from our pharmacists, our infectious disease, critical care. It does take a village to get patients safely through CAR T therapy. But with that trained multidisciplinary village approach, the likelihood of making it through and surviving and being cured is impressively high.
Well, that's a very hopeful note. Thank you for that. And unless there are any other questions, I think that's going to close the program here tonight. So again, I just wanted to thank all of you, obviously, for coming. You guys make the program. Thank our sponsors as well, including the law offices of Nemphos, Braue, LifeBridge Health, Sheppard, Pratt, and the University of Maryland Medical Center. And also a big thank you to Citron for hosting us here tonight. Big thank you to our panel, Dr. Jonathan Thierman, Jennifer Main from Amalgam RX, Marina Cecchini from Sheppard Pratt, and Dr. Aaron Rapoport from UMMS. So thank you again. Don't forget, this will live on jmoreliving.com. So please tell your friends, and any views would be great. Thank you, guys.